So, good morning, good afternoon, wherever you may be joining us from. It's my absolute pleasure to welcome you all to today's Dossiter Health Ethics Center event. Today, I'm thrilled to be joined by Christy Simpson, Fiona McDonald, Joe Conkin, with panelists Tracy Bailey, Brenda Lear, Kevin Yang, and Ashraf Albarawi. I'm also thrilled that we're joined today by Erin Busan and Jesse Linham, the co-leads for the Rural Medicine Interest Group at the University of Alberta. It's wonderful to see future generations of physicians supporting dialogue regarding ethics in rural and remote healthcare practices. Before going further, I would like to acknowledge that the University of Alberta stands on Treaty 6 territory, a traditional meeting ground and home for many Indigenous peoples, including Cree, Saulteaux, Niitsitapi, Métis, and Nakota Sioux. While our university aspires to be a welcoming place for people, it's important to acknowledge that it exists as a settled place on appropriated land. For this fall 2023 symposium, we're proud to be offering 3 sessions. The first 2 will be more traditional presentations with time for discussion after each, and the third will be a panel discussion. We hope that you're able to join us for the entire event, but appreciate that many of you do have other competing clinical, administrative, or just general life responsibilities. So you may have to come in or step out. We're doing our best to record this event as well. While the discussions won't be recorded, the presentations will be, and we'll post links to them on our website. During our presentations, we will be keeping microphones muted and cameras turned off, just to make sure that everyone is able to enjoy the presentation together. But please note that following each presentation, there will be time for discussion, and during which time all participants should be able to turn on their camera and ask their questions. If for some reason you do have a comment that you are uncomfortable asking yourself, please feel free to type it into the chat box directed to myself, and I'll do my best to read it out to you. We are going to try and keep to our rough timetable of approximately 1 hour devoted to each of the 3 sessions. I also appreciate at this point that it's kind of ironic that myself as a physician in newborn intensive care, who works pretty much exclusively in a tiny unit of the hospital, is introducing a symposium on rural and remote healthcare ethics. That being said, I also recognize that the patients that I care for come from all corners of Alberta, and frankly, other parts of Canada as well. So often we do encounter rural and remote healthcare ethics, not only in the context of those settings, but also within our cities and tertiary centers, as different worlds come together, sometimes successfully, but sometimes also bringing with them challenges. I'm excited to be learning more about this topic, and that's one of the reasons, I would say unselfishly, that we chose this for a topic. So without further ado, I'd like to begin by introducing our first 2 speakers, Dr. Christy Simpson and Dr. Fiona McDonald. Dr. Christy Simpson is an associate professor in the Department of Bioethics at Dalhousie University. She is the department's coordinator of the Ethics Collaborations team, which provides ethics support for Nova Scotia Health, IWK, and Nova Scotia Health Ethics Network. She's also an adjunct professor in the Australian Centre for Health Law Research at Queensland University of Technology. In 2017, Christy, together with Fiona, published their book, Rethinking Rural Healthcare Ethics. Dr. Fiona McDonald is an associate professor in the Australian Centre for Health Law Research at Queensland University of Technology, Australia, an adjunct associate professor in the Department of Bioethics at Dalhousie University, Canada, and a senior research fellow at the New Zealand Centre for Public Law at Victoria, University of Wellington, New Zealand. Her research interests focus on legal and ethical governments and health systems, health organizations, and health professions. Without further ado, I'll turn it over to you, Christy and Fiona. Thank you again for being here.
Thanks, Michael. Hi, everyone. Fiona, would you like to kick us off?
Certainly. It's a delight to be here from so far away. I'm actually in Aotearoa, New Zealand at the moment, rather than in Australia. So we'd like to start by acknowledging the traditional custodians of the land upon which we stand. There's been an acknowledgement already of the traditional custodians of the land on which the University of Alberta stands. But we want to acknowledge, from my part, the Ngāti Rangi peoples whose lands I'm standing on today, but also the lands in which I work from, the Turrbal, Yagara, and Ningi peoples. And Christy?
Yes, I'd like to also acknowledge that in Nova Scotia, I'm in the land of the Mi'kma'ki, and that we are definitely privileged to be able to work in this area and beautiful part of the country as well.
And Australia and Canada share similar experiences of conquest and colonization. And we acknowledge that the hitherto dominant approach to health ethics, with its roots in the Enlightenment, does perpetuate the norms of colonization. When we're doing this rural rethinking, a lot of the time, one of the questions we get asked is, what about Indigenous peoples? The rethinking that we're proposing, that we do around rural healthcare ethics, doesn't attempt to create an ethics to govern Indigenous values around health and healthcare. We believe that's for the self-determination of Indigenous peoples to shape. But equally, we acknowledge that bioethics needs decolonising. And all journeys need first steps, and in questioning which we do in this, when we rethought rural ethics, in questioning metronormative assumptions and assumptions about rurality, we're a small part of a broader conversation, challenging normative assumptions. Rural is, to quote Farmer, more than urban with trees. It's heterogeneous. There's no one rural. Every rural community is going to be slightly different. But we also start from the acknowledgement that rural health professionals have much to teach ethics and healthcare practice around particularly the ethics of complex interconnected relationships between people, between communities, and with place. So just a few words to begin with about our orientation for doing this work. When Christy and I started doing this research, we were really concerned about justice, and we were really concerned about equity and equality when it comes to accessing health services and health outcomes. And we were conscious of the fact that there were some challenges and issues but also opportunities for rural communities in Canada, in Australia, and in other countries. We were concerned that rural communities are often positioned as a problem in the context of the health system, whether that is cost to the economy, this concept that if you make a choice to live in a rural area, you have to live with the consequences of that, which includes differentials in access to healthcare, noting from its start that quite often you don't have a choice about where you live for a number of factors, that it's a difficult place for health professionals to work, or a place where health professionals who are not as good as urban-based professionals go. And these assumptions, this positionality, from our perspective, is incredibly problematic. And so it led to us thinking about what ethics could do better to support rural healthcare, and thinking critically about what we teach and the presumptions that underlie most ethical approaches and codes of ethics. And those assumptions, we argue, are quite metronormative. Our approach to ethics draws from critical feminist perspectives, power relationships between rural and urban sectors, and between and amongst neighbours. We consider relationality in the context of community and the context of place. And also we draw from feminist epistemology that our identity is a functional creation of our past and current experiences, where we come from, and including how place, community shapes our sense of identity. And in shorthand, that's referred to as, you can take the person out of the country, but you can't take the country out of the person. So, as Salter and Norris note, the field of bioethics has relied heavily, either consciously or subconsciously, on the particularities of a specific context, and they're referring here to urban tertiary hospitals, for the creation of its most seminal concepts and practices, from informed consent to models of clinical ethics consultation. And again, that's problematic, because the metronormative assumption there, based on a tertiary hospital, is you're primarily providing care to strangers. So how do you negotiate the ethics of caring for neighbours in vastly different geographies and with vastly different relations of dependency and relations of intimacy? Are these types of relationships the same, or do we need to think how to complement existing ethical norms with practice or place-specific ethical considerations? And we acknowledge that the ways in which we've been rethinking rural health ethics has significant resonance also for primary care. What if the ethics that we often teach results in rural health professionals feeling a disassociation between what they're taught and what their code of ethics says and the realities of their practice context? If the nature of being a good health professional is based on norms that are, we argue, primarily determined in an urban context, what does that mean for rural practice? This may result in rural health professionals feeling as though they've been set up to fail when they don't recognize themselves and their practice in these norms. And one of the ways in which this is set up is essentially that any dual or overlapping relationship is problematic, but it is inevitable in a rural context. If you were to manage dual relationships in a way that shuts them down completely, then you would have no patience. Because particularly if you're not in a fly-in, fly-out context, or a drive-in, drive-out, if you're based in that community, these are your neighbors. And that this assumption that dual relationships are bad, and it almost problematizes that ethical relationship from the outset. Heading over to Christy now.
Sure. And so to continue with where Fiona was headed, part of what we want to do is flag and problematize some of the assumptions that are built into both our ethical norms, but also in the ways in which we talk about rural healthcare and living in rural settings. And one of the things that comes out quite clearly in the rural health literature and in the rural health ethics literature specifically as well, is that there's two kind of competing framings that inform a lot of, or form kind of the implicit basis upon which people are discussing and talking about decisions in healthcare, about why patients may make certain decisions, or making them on the basis of health policy, or making health policy on the basis of these perspectives or these framings. And so we wanted to highlight both of these here too. So the one that you see on the slide right now is the deficit perspective. And then I'll also talk about the rural idyll, or the idyllic rural setting as well. So the deficit perspective, as it implies, and the pictures show here too, is the highlighting or the ways in which rural is always less than. So if we take the norm as urban is best, that's where you get the best healthcare, quote unquote, right? Then it means in a rural setting, from a deficit perspective, it's about lack of access to healthcare. It's about not seeing specialists. It's about getting less healthcare in general, and that leads to poorer health outcomes. And there is a sense in which, as we look at our healthcare systems, we realize there is a truth to that. It's not denying that health outcomes might be different. But what we want to do is problematize the assumption that it's always because it's rural. It might actually have something to do with the types of occupations that people employ that are much riskier than a number of urban-based occupations. So farming, mining, fishing are inherently risky in different kinds of ways. But also thinking through that broader piece of how do policies intersect with each other to make it more difficult to access certain forms of healthcare in rural settings. And so I'm just planting that seed. We'll come back to that a little bit later. Then there is, and if we flip this, where we're saying the deficit perspective emphasizes all the worst parts of rural life or rural healthcare, then we have the rural idyll, which then obviously swings us in the opposite direction, and it says, isn't it lovely to work and play in rural settings? And yes, indeed, there is, again, a sense in which that's true. It's beautiful. It's pastoral, it's calm, it's quiet, it's simple. And yet, if we pull into the rural ideal and this kind of sense of everything's so rosy and nice and it's so much less complicated than the urban setting, it also then potentially leads to stereotypes around, well, if the place or the setting seems more simple, are the people there too? So the questions about and the portrayals of the country bumpkin who just is less cultured than their urban counterparts comes into this. The stereotypes about whether people in rural settings can understand the complexities of their healthcare needs and argue effectively for what they need or what would be most appropriate in their community for healthcare becomes a really key part of this. It also glosses over the fact that not all rural communities are thriving. There are a number of rural communities who are struggling, some are dying, and that fundamentally influences the nature and type of healthcare that is provided in those settings as well. And so again, thinking about how do these two framings lead to certain conclusions or certain assumptions about what might be happening in terms of the ethics of care becomes really essential. And so in that sense, then, as Fiona and I continue to kind of unpack and look at some of these different stereotypes and assumptions, it gets us to this type of question that Fiona's already highlighted too, is in that sense, as ever we're thinking about from urban and rural perspectives on healthcare ethics, we're so used to starting from an urban setting and looking that way out, is what's different if we start from a rural setting and look that direction in terms of our healthcare theories and our healthcare perspectives. And so it leads us to the two questions that you see on the slide here. Are there additional or other values that healthcare providers and patients that are using in a rural setting to make decisions about healthcare? And we're not going to claim that these are solely or uniquely part of what it means to be in a rural setting, but more that some of these values become or they're easier to identify in rural settings, right? And then that helps us to start to think about where might those show up in urban settings too, or as Michael was framing at the outset about how do those values help inform your practice in an urban context when you're providing care for persons who have traveled from rural or remote locations. And so in that sense, then we're going to introduce you to three values that we'd like to talk about that come from this type of questioning. Fiona.
So the first value that we identified that is particularly important, we argue, in a rural context is the value of relationships. Again, when you're talking about traditional ethics frameworks, the sort of basis is the care of strangers. But in a rural context, it's often the care of neighbors. And so we're arguing that essentially that we need to revalue relationships and we need to rethink relationships. One of the ways in which I've highlighted so far, and which Jill in the next session will be extending upon, is this question of professional boundaries. Rural healthcare professionals, it's a nature of practice that there's often overlapping or dual relationships between professional and personal lives. And there can be an enormous complexity of relationships between a professional and their patients. These relationships can be framed as creating problems, and this is particularly in traditional sort of ethical guidance, that cause conflicts of interest and negatively affect therapeutic relationship. And so the setting of norm, as in no ethical relationships no overlapping relationships is ethically best, is often one that is taught, that is communicated, and is in codes of ethics. But we need to think about an alternate framing. We need to think about a way in which we can highlight how this adds to the care relationship. It adds to the nature of trust between patient and professional, and it also rebalances or renegotiates some of the sense of vulnerability that is, some argue, inherent in a doctor-patient relationship. So it is mostly unavoidable part of rural health practice, and is something that can be anticipated and should be acknowledged, discussed, and there should be strategies in place to manage it. And we know that rural health professionals have very sophisticated strategies to manage these kinds of tensions. And we need to revalue that as a core strength of practice, and work on developing these sophisticated strategies and translating them from a rural context to an urban context, but also to just authorize, if you like, or broaden our ethical compass to acknowledge that this is okay and that this is acceptable from an ethical perspective. And so part of that is developing an advanced or specialized skill set to navigate those relationships. And that's building on the learnings that are already in place for many who are in rural practice. And this acknowledges the interdependence of people in caring for each other's. Boundaries are renegotiated depending on context, the different situations in which relationships arrive, the different sets of power, and how that power may shift in interesting ways in a rural context where you rely on others and have multiple connections, and that affects that sort of norm of a patient is automatically vulnerable when interacting with a health professional. That vulnerability is potentially balanced through these relationships. The second is the value of community. And so what we want to think about is, what does that mean? We're concerned that community is often utilized as a concept that's more instrumental, so as a means to an end, a way to achieve health-related goals rather than being a value in and of itself. Now, one of the issues with community is that it can be over-idealized, and that for some communities are fragmented, they don't really work. But for some people who are in a community, that concept of community has an intrinsic value for them and is in part constitutive of their identity. So I'm part of this community, and that is who I am. So and then that positively shapes that person's ideas of who they are, what they know, and how they understand their obligations to others. And so we argue that community is a part of some people's identity, and that many individuals, especially those who reside in rural areas, may take the furthest step of having community as a moral value, even if they don't explicitly name it as such. And the value may manifest in what might be termed loosely the obligations they feel towards others in their community, which could be grounded in a sense of solidarity. We're all in this together. Communities have to stick together so that we can make our community work and function. Reciprocity. If I give something to my community, they'll give something back to me, and it might be a function of both. So it might, if we're thinking and we're taking the value of community more seriously, it might entail asking more questions about what it means. What does it mean to not want to be a burden on one's community, and how does that shape your decisions about accessing healthcare services? Whether you can, whether you should, how you do that. To feel that you owe someone some form of caregiving because you've got that sense of reciprocity. To want to be able to give back in some fashion. And above all, to lose connections to your community if you have to leave for healthcare for any extended period of time. And that's particularly in the context of needing residential care, which often cannot be provided in some rural communities. So all of these are actually really important, we argue, for the decision making. It's not just people thinking about their immediate relationships, but also how their relationship with their community will be affected can drive and influence healthcare decision making. And over to you, Christy.
Yeah. And so building in this, I think you'll start to get a sense of where I'm going to head as I talk about the value of place. So as Fiona acknowledged at the beginning, certainly we want to respect and fully appreciate an Indigenous perspective and how Indigenous communities around the world have really begun to express and talk about the importance and spiritual connection that they have to place. And in that inspiring way, right, it then also helps us to think about, for non-Indigenous persons, what does it mean for some folks to then talk about having place as part of their identity as well, or being connected to place, being something that informs their sense of belonging. a connection to the land in that kind of way, or to a particular geography in those senses. And interestingly, in the literature around place and healthcare, place is often then framed sometimes by people, and I'll just quote here from the authors Thien and Hanlon. They said, well, much of the literature treats place as a mere backdrop or container of social activity. That is, meaningful differences in health are acknowledged to exist between places, but these are regarded primarily as a byproduct of other processes known to influence health. And I think what we're doing here is kind of going, yeah, we're with you in challenging. Is it only that? Is place just happens to be where you live and that happens to influence your health? Or for some people, is there this deeper sense of connection about, if I'm not in this place, that will affect my health, or my health is positively affected because I know where I am and I know who I am when I'm here in these kinds of ways. And so in that sense, then you can see how we're building in that piece from feminist epistemology, right? That feminist ways of knowing, which is really that part of, it's informed and shaped who I am as a person, because this is where I live. This is how I understand who I am. And that we're not claiming that that's for everyone. We're not claiming that it's exclusive to rural settings. It certainly could happen in urban locations as well. But recognizing that it is a theme that arises quite frequently in the rural health literature and in rural literature generally, in terms of thinking about health geography, literature, and those other places. So in this sense, then, as we start to take those kinds of insights in and talk about place as a value, about that might actually affect how you're making healthcare decisions, it leads to the types of questions that are on this slide. So what does it mean to be dislocated or uprooted from your place in order to access some forms of care? We talk a lot about traveling in rural and remote communities, about how far do you have to travel to receive healthcare, to access healthcare. We don't tend to talk as much about what it means to be away from that place, to be dislocated or uprooted in that kind of sense, which parallels some of what Fiona was just talking about in terms of the value of community. We don't also talk about, as we're thinking about, will people be able to go back home, go back to their place, about what does it mean to return to one's place, to go back to the place where you know who you are. And if you go back well, that might be quite different than if you go back with ongoing care needs, or if you're going back to that place to die. And I think this brings in some of those subtle shades into conversations where people may not be explicitly saying, I have the value of place. But again, that part of, I know who I am when I'm here, is something that really does start to shift some of these considerations. I think from a person, if we talk about person-centered care or whole person care, we could talk about this in the same way for the value of community or revaluing relationships. But I think it is that part about when we talk about person-centered or whole person care, how attentive are we to some of these aspects? And where do we notice how that might be influencing some of the tough decisions that people are asked to make about being uprooted and traveling for care? And then finally, it also means, what does it mean if you do not return to your place? To have that disjunct be the end of that part of your life potentially, but also because your care needs are so high, you may not be able ever to be back in the place of meaning for yourself. So that also leads me to thinking about, and I was in a discussion earlier today about trauma-informed care. So as we think about creating spaces that are psychologically safe, right, this has started to influence and shape some of the things that I'm thinking about as well in terms of practice in healthcare. And so with this, then, I'll just continue to expand on this a little bit further and sort of what Fiona has shared already too, in terms of a few different examples to help build this through in terms of what we're talking about. So one is to think about now. So sometimes the assumption is made, or you hear it said, or it's written in papers that, well, rural communities take care of their own. Well, yes, some rural communities do take care of their own. Not all rural communities do, though. Or they take care of some of the people in their community, but maybe not everyone. right? So being cautious about the assumption of a rural community is unified, that it doesn't have splits, doesn't have histories around separation, or also have you lived long enough in a setting to receive the same type of care that others might who have lived there for years.
And
Some of
the
the,
other is, do they
yeah,
have
go
the
ahead.
capacity?
To
Do they
provide,
have
they have,
the capacity to do
yep,
that in
yep.
a community that might be struggling?
Absolutely. Absolutely. And I think certainly one of the relevant examples from Nova Scotia too is our community volunteers, who are predominantly rural, are increasingly aging. So there's a frailty and a vulnerability to that informal caregiving network. And so if the assumption is that that informal caregiving network can pick up all the slack, if somebody's going home or being discharged, and the assumption is there that they'll be able to be cared for by their neighbors, we need to be really cautious about this, just in the ways that Fiona was highlighting. We also need to think about allocating health resources for community supports. If this assumption is operating, it may mean, hey, well, rural communities take care of their own. We don't need to invest in formal community supports in our rural communities in the same kind of way that we might do that in an urban setting. And this is the way that you start to see at different levels how some of the assumptions become really important to question from a rural perspective, but also give a different ethical ring to where we think the answers or solutions might be. And interestingly, from a health policy perspective, then some of you might be familiar with the concept of rural proofing. It is something in the broader policy literature that's out there and sort of really trying to help ensure that policies, if you think more at a government level, that policies about how we fund healthcare, about how we invest in rural development, or if we invest in rural development and tourism and internet and broadband and all of those policies, rural proofing is an approach that would argue for ensuring that the rural perspective is included in that policy development process and that it's applied. And I think done really well, rural proofing can lead to rural persons from rural communities or rural perspectives being included as stakeholders and informing the policy development from the beginning. But I think the concern that I have about rural proofing too is it also then kind of demonstrates how deep that urban norm is, that's the default. And there's a concern that I have about, well, if we don't do rural proofing well, I'll use my picture metaphor here. We're not going to bake rural into our policies. We're going to be trying to stuff it in later or add it on, and it will set up more of a conflict between rural and urban communities or urban and rural settings, because it's like, well, oh, now the rural folks want something, and we're going to approach it from that perspective rather than revisiting those assumptions from the beginning. And I think recognizing that there's been changes to the current health system in Alberta that have been announced, I think for me, this raises a really intriguing question about where do the considerations of a rural healthcare perspective fit within that restructuring, right? And where does that go? Is there an opportunity to rural proof the changes in the healthcare system? And I'm just putting that out there as one way of thinking through where this concept of rural proofing goes. The last example that I'll provide and sort of put out there, some of you might have read this in CBC earlier this year, and it was talking from an Edmonton perspective about how some of the hospitals more around, around Edmonton that were being underused, some of their surgical sites were revamped to enable doing some surgeries in those locations. And there's sort of in the article, one of the things that I love about it is it talks about for some patients, they're like, you want me to travel out of the city to get care? And then when they realized that the waiting list was a year shorter, it's like, well, no brainer. I'm going to travel that hour or that half an hour. But also that some other patients from an urban context who traveled out said, I really like the personal touch that came with that care. That there's something different about receiving care in a rural setting that's smaller as well. And so in that model, then sort of seeing, well, what does it mean if we flip those assumptions about who's traveling? So this includes the physician specialist, the surgeon is traveling, but also in trying to achieve better distribution in terms of waiting for certain types of surgeries, that the ask was for urban patients to travel out. And I think that kind of reversal it led to a really long article in CBC about that. Kind of says both it's a nice challenge to the norms and the ways that we typically think about healthcare in a Canadian context, at least, but also then says, what can we learn by asking people to shift differently about who travels and why they travel and what types of innovations that might lead us towards. So with that, I'll hand it back to you, Fiona, for wrapping up.
So I suppose our key messages here really are that context matters. It matters enormously. And that we're sort of just assuming that every place is the same in the ways in which we structure our ethical thinking is enormously problematic. That there are specificities that are associated both with rural and remote care, primary care, and various other forms of care that really do and should affect the ways in which we provide care, the ways in which we think about the ethical issues associated with care. Context matters. And even within that context, it's really important to understand that there's no one rural, that there are different experiences of rurality, and that those draw from what we've termed the deficit as well as the idyll. So there's no one reality of a community that is solely an idyll or solely a deficit. There are always going to be layers, and those layers are negotiated differently. But the ways in which those layers are then used to stereotype rural residents, but also rural professionals, needs us to think critically about the impact that they're having on the ways in which we provide care. We focused quite a lot on discussing the impact of those stereotypes on patients, but we also know from the literature that it's a problem for professionals, that professionals who work in rural communities can often feel patronized by their urban counterparts who make assumptions that they're not up to date in their practice, that they are maybe not as good because they choose to work in a rural setting, or maybe that they didn't choose to work in a rural setting, that was all they could do because only the people who aren't good enough to work in urban centres go and work into rural practice. And we know that that's not the case. We know that enormous innovation in patient care can come and does come from rural settings. But these stereotypes dominate the experiences that rural and remote residents and professionals have in interfacing with the sort of metronormative systems and norms that are involved in the provision of care. And because this context really matters, this is why we think we need to really rethink rural health ethics. There's an enormous value in naming, discussing, and addressing ethics issues in rural settings. And one of the specific advantages is that we can celebrate the innovation that is often inherent in rural care and the sophistication that often comes from the management of these complexities in relationships between people and communities and places. And that critically thinking about these things can refresh, inform, and reshape traditional approaches to ethics, generally and in practice. And this is really important so that we can think about what is considered and utilized, as well as what is taught, and also how medical practice, nursing practice, the provision of health settings in rural and remote communities in Canada, in Australia, in Aotearoa, New Zealand, etc., can be reshaped, not just at the practice level, but also the level of policy and that critical thinking about how we distribute resources at that macro level. And that is, we are very efficient with time, so we've got lots of space for questions. So please, we are very happy to receive them. Thank you.
Yeah, thank you. Yeah.